Without much ado, I'll just call upon the first speaker for this session, and Dr. Rajesh Joshi, to speak about Trypan blue, which concentration is suitable. And the timer to be set for 5 minutes. The organizers make note, the timer to be set for 5 minutes.
Respected judges and my dear friends.
इधर नहीं आ रहा है, एक मिनट. Timer नहीं आ रहा है.
Yeah, it is there.
No, here we can't see. Yeah, it's there. Up.
I will be presenting this paper on Trypan blue, which concentration is suitable. Nothing to disclose. As you all know, continuous curvilinear capsulorhexis is an integral part of cataract surgery, and the visualization of red reflex is essential for proper CCC. In the absence of red reflex, the initiation and the completion of the CCC is challenging. In mature cataract, the red reflex from the retina is absent. Therefore, the staining of the anterior capsule with the dye is recommended. The normal concentration of commercially available Trypan blue dye in market is 0.06%, and it is available in 2 ml vial. The problem reported in the literature due to this normal concentration of Trypan blue dye is the toxic anterior segment syndrome and permanent discoloration of the hydrogel intraocular lenses and inadvertent blue staining of the posterior capsule with its use. Therefore, the aim of the present study was to evaluate the exactly which concentration of the Trypan blue dye is suitable for the successful staining of the anterior capsule in mature cataract while decreasing the chances of its side effect. It was prospective, observational, comparative and interventional study done in the Tertiary Eye Care Center Institute in the Central India from December 22 to February 23. Ethical approval was obtained from the ethical committee. The sample size was in each group was 41 eyes with the confidence interval of 80%, and in group 1 the staining was done with normal concentration of the dye. In group 2 it was diluted in 1:2 proportion. In group 3 it was 1:4, and group 4 it was 1:5 dilution. The inclusion criteria was mature senile cataract. Exclusion was immature cataract, eyes with small pupil, complicated cataract, traumatic cataract, subluxated, one-eyed patients, and eyes with visible red glow, developmental and congenital cataract. Routine preoperative assessment was done in each and every patient. Single surgeon performed all cataract surgeries under topical anesthesia. This shows the staining of the capsule with 0.06%. The video is not working, in fact. Let it be. It was downloaded, in fact. Anyway, yeah. It was stained with all the concentration, and as you decrease the concentration, the staining of the anterior capsule was reduced. The assessment of the staining characteristic in each group was performed with in the form of visibility of the anterior capsule staining, initiation of the anterior capsular flap, CCC completion, surgical time for CCC, and the CCC extension. Visibility of the anterior capsule during phacoemulsification and the placement of IOL in the capsular bag was done. Criteria studied for the scoring of the various staining characteristic was ease of the staining, initiation of the anterior capsular flap, visibility of the staining, and the ability to perform anterior capsule opening. Ease of the staining was done from +1 to +3 with the difficult staining +1 and easy one with +3. The mean age of the participant was 67.42 with 98 females and 66 males. The type of the cataract was hypermature Morganian cataract. In 50 eyes, 60 eyes had hypermature sclerotic cataract and 44 eyes had intumescent cataract. This shows the staining characteristic in each group. With decrease in the concentration of the dye, there was reduction in the staining of the anterior capsule and the initiation
Please
of the
go
flap,
to the conclusion.
But it was possible to stain the anterior capsule. This was the mean CCC time. It wasn't significant. The CCC extension was done in 2 cases with 0.03% and 0.015%, and 1 case in 0.06 and 0.075%. None of the patient had anterior capsular catch, none had PCR, and no patient had elevated IOP on first post-op day. This shows the histopathological photographs in both the stained groups, and there wasn't any difference in the staining characteristics. We could find out two studies in this group, one by Melis group and the other one was Marbeck. We used less concentration than mentioned in the above studies and found out that if the eye is used if the less concentration of the dye is used, 0.025%, that is 0.075, still the CCC is possible and easily can be done without any complication. The key silent features of the study was most of the other studies have stained anterior capsule under OVD. We stained anterior capsule under air, that too using single syringe filled with air. The single stage technique requires very less time as compared to OVD, yet the surgical time for performing CCC was significant. The strength of the study was prospective design, sufficient sample size, and intraoperative factors such as time for CCC completion, visibility of the margin, and complication were studied. This was the limitation of the study. And so the conclusion of the study was with low concentration of the dye, it was possible to stain the anterior capsule, which is economical for high volume cataract surgeries. And this is an implication in developing countries and potentially decrease the cost of the surgery. Thank you.
So what do you recommend your study? Just what's the recommendation from your study?
Recommendation is that we can use less concentration. As you can see, if you have a single case like, and if you use 0.06%, which is available in 2 ml vial, the other rest of the volume of the vial is wasted. If the manufacturer can reduce the concentration as well as amount of the dye in the vial itself, a lot of money can be saved. It would be economical for the surgeon point of view as well as for the industrial point of view.
Have you got any observation on the elasticity of the lens capsule on different concentrations?
Not yet. That was beyond the scope of the study.
Okay.
Yeah.